the suction probe. The suction probe itself was suctioning all the fluid within inside the swelling in the cells, and that caused the canal to collapse. So inadvertently, the suction probe was actually suctioning the canal, and it caused the canal to collapse. So I had to come out, and I've just re-entered now using a fine end suction probe, and we're just clearing this debris. Now, it is quite a long procedure. It took me around 10 minutes in total, and that's because what I want to do is remove as much debris as possible. The patient had actually visited another clinic who said they wouldn't be able to do this, and they would need to go to the doctor and have some medication prescribed, which is correct, they will do. However, for the medication to take effect and be most effective, it's quite important that we try and remove this as much debris as possible. When there is this infected, it's got this much discharge, when you put antibiotic spray or drops into the ear, for example, it's going to get diluted by all this infection, and it will cause all this discharge to crystallize. So the debris will still be there. So if I can remove as much as debris as possible and reveal the eardrum and reveal the ear canal, then the drops are going to be more effective, or the antibiotic spray is going to make direct contact with the canal wall and kill any bacteria or stop it from reproducing at least. Now, people often say, how are you able to, you can see that, sorry, just going to go back, you saw the canal collapse there again, so when I went in the suction probe. So the physiology behind that, I'll just explain again, because just for any Clearwax delegates watching this, so people who have trained in performing endoscopic earwax removal, when you have edema, so inflammation, the cells are full of intracellular fluid, another bacterial fluid, and when you suction, the suction probe itself is suctioning that fluid, and as that fluid is trying to go to the tip of the suction probe, obviously the cells are drawn closer and the ear canal collapses, and again you can just see that, and it can be a difficult thing to work with. You can see again it's collapsing quite a lot at the moment. So this otter is it's a horrible substance to remove. It's very thick, it's very gloopy, it can block the suction probe, and when you're using a fine end suction probe, it's a lot narrower, so it's a lot more prone to getting blocked. So quite often the suction probe got blocked just like it did there. I've had to come back out and I've had to clear it. Now we still can't see the eardrum here, and so quite often people ask, how are you able to perform, or are you able to perform endoscopic procedures in narrow ears? Well, this is a great example. It illustrates that you can, and in fact, once you're skilled and have got the appropriate training, it offers you a much better view of this ear. An alternative method of removing this would be to using a speculum, which is kind of almost like an ear funnel. And by using a speculum, it automatically narrows the view. So this ear canal is very narrow, it's already inflamed, and it's going to constrict the view even more. So once you're skilled in endoscope, there's no ear that you can't actually perform procedures in, and the view it offers, as I said, it's unparalleled. So we're just at the roof of the ear canal here. This is almost like caramel, this consistency. It's very thick, very viscous, and again, it's just blocked the tube. And you can see how inflamed the outer part of the ear canal is. It's really, and the ear canal is quite angry, it's red, you've got all these dry skin flakes, which is very a typical landmark of otitis externa. The patient will, we've written to the patient's GP for them, and they will need some treatment for this, typically antibiotic spray. It can take 7 to 14 days use for it to be effective. Now, we're just directly on the eardrum now. This debris has somewhat crystallised, and it's crusted on the eardrum, and I think it's at this point I will remove this. You can just see where to the left, the bottom left of the suction probe, it's a bit darker, and that's where it's kind of crystallised, and I think I worked from that point, and I managed to peel a lot off the eardrum directly. So again, I'm just entering with the endoscope, although the ear is very, very inflamed, very narrow, still be able to get access. And what I'm able to do now, I'm inserting the endoscope past the swelling to keep the canal ajar, keep it open so it won't collapse. So the eardrum is actually behind this debris, this layer of gunk, otter, and there's the bottom part of the eardrum, so that's that crusted dry skin that I was referring to. So at this point already, the patient could hear significantly better. But again, I want to remove as much debris as possible. So we've got some dead skin here at the bottom, at the base of the ear canal, that I'm gently just peeling up and away. Now, I don't remove every little last flake of dead skin or debris. It's just not humanly possible to do that. We'd be there all day. But I was pretty pleased with what I was able to do. So with these cases, I don't use irrigation or syringing at all. I don't use any water in any of my procedures. Water has got inherent risk. If you're an avid follower, a viewer of my channel, I always advise against allowing water to enter the ear. It can have disastrous effects. You just saw there, I just removed a large piece of dead skin off the posterior canal wall. So posterior means the back part of the ear canal. And yeah, you wouldn't use water, even if I perform irrigation and offer that service at my clinic. When you've got an active infection like this, it's a contraindication. You should not be putting water in this ear. I know from reading a lot of the comments stateside, across the pond, irrigation's still being used quite a lot, but you wouldn't be able to use that in this kind of procedure. It'll just exacerbate the infection. It can get it even more nasty. You could develop another infection called necrotizing or malignant otitis externa, which can be really, really dangerous actually. It literally starts eating up all the flesh and the bone and all the structures around the ear and the jaw and the facial nerve, and it can go upwards towards the brain. So when you've got an ear infection, you've got to be really careful. I think the guidelines in the UK is that you're only able to perform irrigation if an infection's been resolved and alleviated for at least 6 weeks. For me, I think that's a bit too soon anyway. So we can see the bottom half of the eardrum, and I'm just using the fine end just to remove some of this gunk, so it's arteria, dead skin off the canal walls. You can see initially when I insert the endoscope into the ear, there's a bit of fogging there, a bit of condensation and misting of the lens of the endoscope. And that's because when you've got an ear infection, the temperature is increased, which then causes condensation to the coldest part, which would be the tip of the endoscope. So you get water droplets on there. But as soon as I go in with the suction probe, it demisks the endoscope to get a really clear view. So we've got some more debris out there. So again, it's quite foggy, as you can see, but as soon as I enter the suction probe, and the canal's just about to collapse, so I just retain the suction probe there for a second. I didn't want to enter any further to cause it to collapse, and once it settled and I felt it wasn't going to collapse anymore, I just went a bit further in with the suction probe. So you kind of have to judge it as well. Sometimes you can preempt when it's going to collapse, and you just pause. Sometimes you just have to withdraw. You've got no choice. You just have to come back out and go back in again. So we've got some dead skin in the inferior recess here. So some of the arteria gunk on the eardrum is very crusted indeed. And in the anterior recess, it's very embedded. So I think I managed to get a bit more out there, but you can see the whole eardrum there. But the eardrum itself is infected. It's the otitis externa of the eardrum. So it's got a very dull appearance, very wrinkled appearance. And you can see I'm slowly creeping forwards onto the eardrum, trying to remove some of this debris, but it is embedded now, so I don't think there's much more we can remove. Let's see, I'm just literally kissing the surface of the eardrum. You can just see the hammer bone revealing itself, the red part of the eardrum that's running from 12 o'clock to the middle. So this is a before image of the ear with all the discharge gunk, and in a minute you're going to see